All right, good afternoon, everyone. Welcome to our last session of the day today. My name is Megan King. I use she, her pronouns, and I am one of the organizers of this series from the Washington Poison Center. Before I turn the session over to Dr. Patati, I have a few housekeeping items to go through. This session is being recorded. We will make all recordings and slides available by early next week. In order to earn your certificate of attendance, you must watch a minimum of 5 live or recorded sessions by September 15th. As a reminder, we are not able to provide CEs or CEUs, just the certificate of attendance. So please ask your questions if you're watching in Whova in the Q&A tab that's on the right-hand side of your screen. If you're watching in Zoom, you can enter your questions into chat. Dr. Patati will answer those questions as they come, so please pop them into Q&A as you think of them. So that is it for housekeeping. Now I get the pleasure of introducing our speaker, Dr. Patati. Dr. Patati is a medical toxicologist and graduate of the Rocky Mountain Poison and Drug Safety Fellowship with a research focus on envenomations and weapons of mass destruction antidotes. He currently serves as a consulting toxicologist for us at the Washington Poison Center and the Department of Defense's Advisor Toxicology Program. His previous experience includes roles as Associate Program Director, UNLV School of Medicine, Emergency Medicine Residency, and multiple military deployments to Southeast Asia and Africa. Welcome, Dr. Patati. Thank you for spending some of your afternoon with us today. I'll turn it over to you now.
All right. Thank you, Megan. And everybody can see that first slide, I hope. So what we're going to talk about over the next hour is club drugs. And I want over the next hour or two to leave this open for discussion. I know we've got a lot of different folks on the line with a lot of different backgrounds. So please get me those questions. I don't mind stopping to answer those as we go on, because we start from the order of most likely and go on as long as we can to kind of fill that hour. So I'm looking forward to your questions. So where are we going to go? Well, we are going to go wherever this talk may lead, and your questions as well. But we're going to start off by kind of defining what exactly a club drug is. First, you got to define where this club is. It can be a rave, which sets up in a barn or an old church. It could be, your standard nightclub. And the thing is that where the environment in which people take these club drugs really sets them up for adverse events and plays a lot into what kind of drugs they're actually going to choose to use. So these are the main medications, main drugs that we're going to talk about today, and kind of in order of most abuse potential there. When we talk about the most popular club drugs, the number one by far is MDMA. And I'm sure everybody's heard of ecstasy or Molly. It is the number one club drug in all the literature, and by far is the most common. And then when it comes to the other drugs that are involved, the location and the type of environment really plays into what's used. For example, cocaine isn't really used in a lot of outdoor festivals. It's more private, more indoor location, nightclub situations. Whereas LSD is going to be a main player at those outdoor music festivals, particularly EDM. So it's going to play a lot into it. What I've got here is a relative number. So you can kind of see not necessarily how dangerous a drug is, but how often it leads to death. In parentheses here, we're using NPDS data that shows how safe you could make that interpretation these club drugs are. In 2021, in the NPDS annual report, MDMA by a single agent, not in combination with other drugs, caused 0 deaths or was attributed to 0 deaths. And the more popular drugs in this list also had low numbers like LSD, ketamine, and GHB. Whereas kind of where you get to the less often used, less popular medications, you get to a lot more single agent adverse events and deaths, like with methamphetamine. And then obviously the less popular drugs also have less adverse events, but they're just not as highly used when it comes to club drugs. So we've got a mix of drug classes as well. The ones in red are stimulants like cocaine, methamphetamine, MDMA. You've got hallucinogens like LSD and a number of synthetic hallucinogens, which we may get to a bit later. You get dissociative anesthetics like ketamine, and then sedative hypnotics like GHB and flunitrazepam, that is often more commonly called Rohypnol. So a lot of different classes out there and mixes and matches. But the most common ones you're going to see are MDMA, the stimulant medications, because when people are going to the club, they want to be able to stay up all night and have fun. So it's going to be the most commonly used. And that fits with the most commonly used drugs overall. The Global Drug Survey out of 2020 actually surveyed drug users who were able to be contacted over the internet to see exactly what drugs they were using. So these are self-reported data, and MDMA, cocaine, LSD, ketamine, GHB are all up there on this list, far behind alcohol, cannabis, and tobacco, but you can see that these are very, very popular in anyone who uses drugs. But this chart here on the right is also very interesting, and it describes how often people are actually reporting that they went to a hospital after each of these medications that they took or drugs that they took. And you can kind of see that heroin leads the way, and it is not a club drug. Methamphetamine is, but it's at the bottom, and you can see that there's a lot of side effects with it, and people are choosing some of the more safe medications. So LSD, cocaine, MDMA, they only have 1% of users reported having to go to the emergency department after their use. So there's some self-selection here because people want to have fun, and they also want to be somewhat safe. And we see that becoming a more and more popular thing over the next last few years and decades, as people wanted to have a culture with their club drug use, whether it's at electronic dance festivals or with clubs, nightclubs, that they want an environment where they could safely use. And what we found, though, is that when we weren't doing harm reduction, that there were a lot of bad outcomes but there's not a lot of literature to tell us how many there are. If you look for news articles about big music festivals, you might find 1 or 2 deaths a year. And some of the bigger ones, you might have 10 a year. But there was a Canadian author who searched all the gray literature and was actually able to find 41 cases of overdose deaths over the 10 years of literature that they looked at, going back to, I believe, to 2009. So these events can certainly be lethal, and serious adverse events can come from this. And we'll talk a bit why they make for a perfect storm potentially if we're not doing harm reduction. And part of the reason why people and club owners, festival organizers were reluctant to do harm reduction goes back to the Illicit Drug Anti-Proliferation Act of 2003. It was initially called the RAVE Act, the Reducing Americans' Vulnerability to Ecstasy Act. And it basically extended crack house laws to people that were hosting raves or festivals or the like, and that caused a lot of people to just look the other way when it came to drug use at festivals rather than participate in any harm reduction. But there's some standard themes of harm reduction that you can use at festivals, at nightclubs, that really can go a long way to reducing the side effects of club drugs, which we'll talk about, which can end up being lethal. And recently, what I've heard is that the Department of Justice has put out a letter, at least during the last administration, that said education and water, handing those out do not apply and would not get you in trouble with the Illicit Drug Anti-Proliferation Act of 2003. So those are becoming more popular, but I would say over the last few years, from what I've been able to determine, harm reduction is extended out, and some of these use peer counselors and other means to get drug testing at the sites. and sometimes people have to do it themselves. But it's becoming more and more common that harm reduction is able to be in place at these large raves and festivals. So things that are being seen is free water being available, drug testing, sanctuary spaces where people can get away from the crowds to calm themselves down, and they're being encouraged to have designated trusted friends. And there's peer counselors available as well, often to help talk people down and counsel people on proper use of these recreational drugs. So I'd like to start off with a case. This is a 21-year-old female found vomiting in the bathroom of a club after taking a blotter of what she was told was acid with a person that she had recently met and decided to go out. When EMS arrived, they found her to be disoriented, but vital signs other than a slight hypertension seemed to be okay. And after getting her onto the stretcher after her bouts of emesis, what she thought she was taking was LSD. And LSD has a long storied history behind it, and basically starts off with a medication designed that is similar to a lot of natural drugs out there. LSA is what comes out of this Hawaiian baby Woodrow. And it's a hallucinogen if you can collect enough seeds and use it, but really not a very fun experience compared to what was designed initially in 1938. Was discovered by this gentleman, Albert Hofmann, who is holding the molecular structure of LSD there in his hands. He first created this in 1938, and 5 years later, actually exposed himself to it after going back and trying to resynthesize it and hope to create a cardiovascular drug. But he describes his eureka moment on a bicycle ride back from his lab in Basel, Switzerland, after working with for the Sandoz company, where he had the first trip on LSD while riding back from work. And he describes all the different colors he saw and the amazing feeling of oneness with the universe. And he had no idea what he had just taken. But over the next few months and years, he went back to try to figure out what that was, and was able to determine the molecule, and it started an entire movement of psychedelics. He was also the same person who was first able to synthesize psilocybin and isolate it first. But it started a whole movement through the 60s and 70s, where LSD and hallucinogens, the psychedelic universe was established, and that is the direct forefathers of today's movement with raves and club drugs. People trying to experience things that they would never be able to in the sober world. And hallucinogens, which LSD is the parent compound of, really fall into through a couple different pharmaceutical classes. One being indole-alkylamines. LSD is one, psilocybin is another. Phenylalkylamines, which we will discuss kind of in depth a bit later, are the others. But the terms used to describe these hallucinogens include the entactogen. The entactogen certainly is something that kind of describes our MDMA, and it also describes LSD as well. It creates an emotional sense of communion and oneness. It also create an interaction with your senses, which makes them heightened, and you have incredible attention to finding new senses, whether it's sound, sight, or sense as well. And theogens, on the other hand, things like that are often used in ritual ceremonies, like peyote, or other hallucinogenic compounds that don't seem to have quite the same use in the club drug scene, because it's generally not the experience that people are looking for. With LSD, which this person had intended to use, the way it works is as a partial agonist, a very potent partial agonist of the serotonin receptor 5-HT2A. Now, this is a receptor that almost without exception is stimulated with any hallucinogen and very many psychedelic compounds. Now, it also has some other agonism of other receptors, serotonin specifically, and adrenergic receptors. But one of the things about LSD that makes it unique is that it's concentrated in certain areas of the brain, the visual cortex specifically, as well as limbic and reticular activating centers. The visual cortex is responsible for all those psychedelic visual experiences, and the limbic and reticular activating systems are responsible for the activation, as well as the feelings of empathy and oneness that you will hear when people are describing their experiences. The way it's distributed, if you were to sample someone's blood while they're using LSD, you wouldn't necessarily be able to tell if they're on their way up or down, or if they're having an experience or not. This is an incredible experiment here where 12 men, 12 women were studied and given LSD, and with periodically measuring at the hour mark their concentration of LSD, compared it against the drug effect perceived by the patient. And you can see these kind of circular movements, graphs on the right side, C, E, and G, that people can have the exact same concentration of LSD on the way down and report a much greater effect on the way down than they do on the way up. So you very likely won't necessarily be able to, and you won't get this information right away. There's not a test for a patient when they come into the hospital or to your med clinic at the side of an electronic dance festival, music festival. You won't be able to necessarily have a test that gives it right away from a blood test, but you'll have to use kind of clinical clues on that, or just ask the patient, who very likely at that point will be comfortable to tell you, unless they're experiencing one of the very common side effects of adverse events of having paranoia and concern there, and agitation. So the LSD patient that comes to the ED is often having those psychiatric symptoms: anxiety, paranoia, potentially panic reactions. They may have those hallucinations that is the sine qua non of LSD. That they'll also have synesthesia, which is the blend of sensations, so that you might hear a sound and it be perceived as the color orange, or have a smell that stimulates a sound, because a lot of connections are made between synapses in your brain that don't normally share information. Constitutionally, people will be presenting with sweating. Their pupils will be very large. They may present it with a headache and very fatigued, but only in really severe cases are they going to have much more than that. And oftentimes when those do present, it's going to be because of co-ingestions rather than just LSD itself. So this patient, when they arrived to the ED, had a 30-second generalized tonic-clonic seizure. And by the time we as the toxicology service got to her, she was very paranoid. She was worried that she had lost her phone. She was looking everywhere for it, and it was sitting on the counter right next to her. However, we didn't see that she had any nystagmus. She didn't seem to have any tremor. And though she had some diaphoresis and large pupils and tachycardia, she only had mildly increased reflexes and just a few beats of clonus. Getting at what medical history we could find from her based off of what we had in the medical record, we determined that she was also prescribed lithium and escitalopram, which is an antidepressant that can raise serotonin in the synapse, and has some side effects of its own in overdoses. So that was one of our differentials, was this an overdose of a home medication? And it turned out that her lithium was non-detectable, and that the main side effect of escitalopram that we worry about with big overdoses, other than serotonin syndrome and EKG showing QTC prolongation, that was just slightly elevated, but not to the point where we were worried she might have torsades in the short term. Her EKG also showed a narrow complex QRS, and then all of our screening labs otherwise were really unremarkable. So things were looking okay for this patient, but she had a seizure, and that is not common with lithium. Sorry, not common with LSD, though it could be with other medications that she was on, because LSD has that partial agonist effect on 5-HT2A. It often doesn't have an incredible surge that you might see in association with serotonin syndrome. That's often a complication with co-ingestions, which we had no particular history of. But this patient had a severe outcome, having a seizure after ingestion. So we really had to question whether or not this person actually had been exposed to LSD. We had to first determine whether or not she also had something called serotonin, serotonin syndrome. We used something called the Hunter area criteria, which is a stepwise diagnostic algorithm for determining if somebody has a toxicity from a serotonin agent like an SSRI, like MDMA, like in this case, yes, LSD is a serotonergic agent, but it doesn't really cause serotonin syndrome very often. But this patient could have been diagnosed with serotonin syndrome, and that she had slightly increased reflexes and a tremor, but it was really a borderline case. All right. And the main thing that we worry about with serotonin syndrome was when people get hot. Okay. Moderate and severe cases are really defined by when people get hyperthermic. And this patient, fortunately, was normothermic. And we were imagining her agitation with benzodiazepines. But this nice review article by Dr. Gilman, who writes a lot about serotonin syndrome, if you ever want to read more about it, talks specifically about LSD. And after reviewing 50 years of case reports and literature on serotonin syndrome, did not find a single case that could be attributed to LSD as a single agent. And typically LSD is in very small amounts and can have profound psychological effects at those small amounts. So it's not the case that often people that use a lot. And in the cases where people did abuse, like there's one case report where people thought they were snorting cocaine and used about 100, potentially 200 times the dose that it's typically used for LSD. And those people almost all had recovered within 12 hours. It's pretty rare for LSD to be causing seizures and serotonin syndrome. But what's not rare is for this LSD to be contaminated. In this case report, or this series of cases coming out of Brazil, they found up to, in this particular case, that it changed over time, and found that back in 2011, almost 100% of LSD cases, blotters that were tested by their government, the public health measures, were LSD. So sold as LSD, 100% were LSD. That went down to 0.1% in 2014, and then back up to 17%. And now they were able to detect multiple substances. And one of the things that is very often being placed on these are chemicals in the 2C class. These are hallucinogens, but in the phenylethylamine class. And one of the big ones that people are worried about, and you'll have when you're doing harm reduction and testing, people asking about are substances like N-bombs, and a new substance based off that, the NBOH. And these are chemicals that were really designed by Alexander Shulgin back in the 60s and 70s. And a very interesting read if you want to read about psychedelics and the movement there. This is a fictional autobiography there with PCAL, and it's a subsequent TCAL book, but it stands for Phenylethylamines I Know and Love, and describes how he and his friends, both his wife and very good friends, would find a new substance, try it, explore it, and if they liked it, would try to modify it in some way to make it a better experience. And in that manner, explored dozens of new compounds that had very different effects. But some of these we now deal with as contaminants for our major club drugs. And you can kind of see here that all you have to do to have almost dramatically new effects or change, one atom here or one atom there, switch around a halide molecule like an iodine for a bromine, and you might have a chemical that has profoundly more hallucinogenic effects, or one that lasts a lot longer. It's a way that Alexander Shulgin kind of explored the psychedelic movement. But for our patients that we're dealing with, will potentially be surprised if it's a particular contaminant, and may come to the harm reduction table, or may be asking counselors for advice on what particular ones are safe. And of course, there's no safe club drug, but some are definitely more safe than others. All right. The 2C intoxication. Now, this is a class of medications, or sorry, class of drugs that Alexander Shulgin made, but he made it because the 2C stands for the two carbons between the amine group, that nitrogen group, and the phenyl group. So there's a wide range of compounds that satisfy that. But he had developed many of them, and those not only did the hallucinogenic effects that you might see from LSD, and serotonin effects that you might get with that feeling of empathy and oneness, but you'd also have more sympathomimetic effects, meaning you'll have more of that methamphetamine, amphetamine effect of alertness, and it might be extended in the amount of time that you'd feel that. But the syndrome that you might exhibit with a 2C intoxication fit more with this patient's picture. Alert senses, hallucinations initially, and then dysphoria, and you might get seizures and delirium when it comes to the emergency department. So it's very possible this patient had a 2C intoxication, got a bad blotter, and really, when it comes to the emergency department, what we're going to do is treat the patient based off their symptoms. If they're seizing, you're going to use benzodiazepines. If they're having an acute psychosis and they're having, and you can't just calm them down, you're going to use an antipsychotic potentially. So there's not a whole lot of reason other than to just document what a patient took to figure out exactly what this chemical was. All right. The next thing I wanted to talk about, and I'll use the 2C compound here as kind of a jumping off point here. The case 2 is this: as a 19-year-old man brought into a medical tent at an electronic dance music festival, and he's very clearly hyperthermic. Initially, almost comatose with his GCS of 4. His heart rate was racing at 160, and he's very hypertensive and breathing fast. Now, the drug that this particular patient was using was MDMA. Now, we learned above that MDMA is a pretty safe medication or drug, and that only 0 deaths have been recorded in the annual report for 2021. And of course, there had been in years past single agent cases where people got hyperthermic, but it's pretty safe. So something about his environment caused him to get that sick. But typically MDMA is going to create a profound sense of euphoria, a sense of intimacy and well-being, but it is going to have a slight sympathomimetic effect, but not as much as amphetamines and methamphetamine. It's going to have serotonergic effects, but it's going to be far less hallucinogenic than LSD. So this is kind of one as the just the right Goldilocks type of club drug. And you might find people that are on this maybe yawning, but one of the things that happens and really may help you is something called bruxism, so grinding of the teeth. And other than fashion, which you might pick one of these up just because they look cool. At a rave, you might find somebody who's on MDMA using a pacifier to keep themselves from grinding their teeth and damaging their teeth. And it can explain a few things if you had ever wondered why at raves people are using that. It acts on a number of different receptors: serotonin, dopamine, norepinephrine. It also inhibits the breakdown of those compounds, and it causes a hormonal surge. One of these hormone surges is prolactin, which is thought to explain that profound sense of connection and togetherness with other people. It's kind of letdown hormone that moms have when breastfeeding. So interesting that hormone is increased specifically by MDMA. And the other chemical I want you to kind of keep in mind is that of ADH, an antidiuretic hormone. But in severe MDMA overdoses, you're going to have the serotonin syndrome, which I talked about before, and sympathomimetic toxidrome. And specifically, both of those can lead to hyperthermia, and the consequences of that can be multi-organ failure, rhabdomyolysis, cerebral edema, and death. Now, that ADH, the antidiuretic hormone that's released, can also cause hyponatremia by itself. That's a low sodium count all by itself. But when we're talking about people that are told it's a festival, you can get very hot, make sure you stay hydrated, drink lots of water. People can take that very literally and become hyponatremic, just like a marathon runner would who's drinking a lot of water for the same reason. So that's what happens in severe MDMA. This hyperpyrexia syndrome is what this particular patient had. It's number one thing is hyperthermia, of course, but people are going to be comatose and be very rigid, and their muscles will kind of be breaking down. So you'll see that in blood tests and urine tests as well. Their liver may be affected. They may be profoundly acidotic with a lactic acidosis. And then at the final stages, they may have severe bleeding disorders before multiple organs failures and die. And this is why we have harm reduction at music festivals and raves, is to prevent this syndrome. And a lot of people have investigated ways to eliminate it. And one of the easiest and best ways is through prevention. Now, when the Army is doing a ruck run out in the heat in Georgia, they're going to prepare their soldiers by having ice baths along the way. And one thing they do is, and it's pretty safe and inexpensive, but they dunk their forearms in these ice baths beforehand. They don't have to get completely wet, but it can lower the core temperature quite a bit. And if you do that periodically, you can avoid yourself getting severely hyperthermic. But the big thing is environmental controls. And there's a number of rat studies determining what exactly environmental things contribute to MDMA causing hyperthermia. And one of which is the ambient temperature. Temperature that is cold in the like 5 degrees Celsius range. These mice, if you give them MDMA, are not going to just on their own develop hyperthermia. However, in a 24C environment, they will by giving them MDMA. The more rats you put in together, the more likely they are to have MDMA, and the more stress you cause the patient, the more likely they are to have a hyperthermic event. So these things are all exactly what's going on with raves and big crowds. And so this is where harm reduction comes in as well, by having those separate environments, those sanctuary areas, get people in a cool environment away from other people in a less stressful environment can reduce the risk of this hyperthermic event for our patients and may allow them to kind of live longer. And so environmental controls are very important. But when it comes to chemically interfering with that process to develop hyperthermia, the big thing is that we need to antagonize that 5-HT2A receptor that we talked about earlier, that LSD hits in a partial agonist way, and MDMA hits specifically as well. But if we have an antagonist, and we use this in medication as well, the medications we can use to antagonize in people are cyproheptadine and chlorpromazine. Chlorpromazine can be given IV, but cyproheptadine has to be PO. But if somebody has a early serotonin syndrome where they can take pills, that's something that could be administered at a rave or at the medical tent at a festival. There's also other antipsychotics like risperidone that have specific antagonism of that 5-HT2A receptors, but oftentimes other antipsychotics don't and may not be as helpful in preventing that hyperthermia. And the other thing is GABA agents work equally well, what we choose to do. And these are medications like diazepam, lorazepam, and midazolam. Those medications are going to definitely reduce the amount of risk for our patients to develop hyperthermia. And when somebody comes to the medical tent, they're going to be treated with these class of medications specifically initially. But one thing that is very interesting in the debate specifically for MDMA is the use of dantrolene. Dantrolene is a medication that is used specifically for anesthesia-induced hyperthermia. where in certain people, they have calcium receptors in their muscles that continually release calcium and cause muscle contractions without any signal to actually for that muscle to contract. And dantrolene counteracts that chemical that receptor's release of calcium. And in a number of case reports, people have tried dantrolene specifically for MDMA induced hyperthermia, and at least by the numbers that they've got, they get very rapid cooling, and they've had a number of good outcomes. Some people with temperatures like over 106 that are able to walk out of the hospital a few days later. But the mechanisms that we talk about for MDMA, we talk about how hyperthermia is generated by the heat from movement. So people are at the club, they're moving around. They also have failed cooling measures. They don't take off clothes when they get hot because their behavior is altered. Peripherally, they're going to vasoconstrict, which means they're not going to give enough blood to their fingertips and peripheral skin to cool down. And there's also something called uncoupling, which happens in the brown fat that you've heard with babies being used so they can generate heat without having to move around a lot. Uncoupling can be induced by MDMA, specifically through norepinephrine release. But dantrolene is a big controversy, and there's authors who are very pro dantrolene and authors who say that makes absolutely no sense. In my opinion, we're going to do the things that we know chemically work, the GABA agents, those 5-HT2A antagonists, and we're going to do big cooling measures, which we'll get to in just a minute. And if those don't work, I'm going to advocate that you can try dantrolene, because it's possible that you may have induced a similar chemistry to what happens when people are coming out of anesthesia, and you can help them with that. There's also a thought that when people are very hot, those particular ryanodine receptors, which dantrolene affects, have a very lower set point where they can stimulate calcium release. So it's thought when you're hyperthermic, that sensitivity is way too low and can cause muscle contractions. But really, what you need to do is get people in an ice bath. And you can do this at festivals. You can do this outside of raves. You can set up a horse trough and load it up with ice and water and just have that ready to go. In one study, which wasn't published, but just discussed in some newspaper articles, their protocol was to have these ice baths ready. And when a patient came up that was identified as being hyperthermic, they immediately put them into the ice bath while medics were working on IVs. And while that was being done, the person was being prepared to be intubated and given dantrolene. And so that intubation typically is going to need to have a paralytic and medication to sedate as well. So all these things were going all at once. And they reported some really good numbers of severely hyperthermic patients making out of the hospital a few days later. So early aggressive symptomatic treatment of a hyperthermic patient is really going to pay dividends, because it's really how long somebody's brain stays hot that is attributed to how much brain damage they have and multi-organ dysfunction. So rather than necessarily lining that patient up to go in an ambulance where they may not be able to cool very efficiently, if you can set up through harm reduction places where people can cool off very quickly, we might be able to save a few more lives and keep that 2021 data where nobody died and extend that for a few more years. That other thing that MDMA does, causing severe hyponatremia, the effect of that can be such that you do develop seizures from hyponatremia. And then if you correct it too rapidly, you can get some severe effects on the brain that's irreversible as well. But if somebody is seizing after coming out of a rave or a EDM, and you've got some laboratory measures, you can confirm if they're hyponatremic. But if you see a bunch of water bottles, or if they know their friends come with them, and they've been drinking a lot of water, this needs to definitely be thought about, because a refractory seizure from hyponatremia may be very responsive to hypertonic saline. So saline, giving that salt back to the patient to balance it. typically what we're going to do is give 100 milliliters of 3% saline fairly quickly. You can use a peripheral vein if somebody's seizing, and you may repeat it again in 10 minutes. But if somebody's seizing, you need to act quickly to rule out that hyponatremia was a cause. And really, if you give 100 mLs of 3% saline, it may raise your sodium content, 1 or 2 points, but it's not going to it's not going to cause severe problems with this one bag, but you may abate the seizure and buy yourself enough time to get the patient controlled. But MDMA also has this problem with contamination that we described with LSD earlier with the N-bomb. This is one particular study that looked at English market and looked at COVID-19 lockdown specifically. So looked at the period before we had our COVID experience and found that MDMA was relatively pure, but during that time frame when people were staying at home and supply chains were restricted all over the world, substitutes started coming in, and those range from caffeine and synthetic cathinones, which basically bath salts, and those act a lot like methamphetamines. They really amp up the sympathomimetic pathway more so than the synthetic serotonergic pathway. So a lot more agitation and excitation rather than hallucinations or the euphoria that you might get with an MDMA. So contamination is a real thing for MDMA, which goes towards why we need harm reduction. Now, there's a big debate about MDMA and whether or not it's neurotoxic. From the literature, it's pretty clear that after a short course of MDMA, your serotonin receptors are downregulated. Your brain will try to adjust to that surge of serotonin. But in some studies, that evidence could last pretty long, and the depression that potentially results, a depressed mood, sometimes is reported in the literature to last several weeks after abstinence. And we're not certain how long that downregulation will last for a patient who is abstinent. And we also know that severe surges in monoamine oxidases, specifically dopamine, can lead to neurotoxicity. We're not sure if those nerve deaths that might occur on the serotonin side can be recovered. But we do know, at least from survey data, people that self-identify as regular MDMA users will have associations with depression and difficulty with cognition. So I know we discussed, there was another talk at this conference about the use of psychedelics in therapy. I think those are the perfect environments as far as controlled trials to really study this question of whether or not neurotoxicity comes from these medications when it comes to normal use. Because a lot of times you can't separate hyperthermic events and damage to brain tissue and separating patients who had really been exposed to methamphetamines and those sympathomimetics that are known to cause real neurotoxicity. And it's hard to make that answer develop from the literature that we have today of whether or not it's really damaging to the brain. So again, long term, we don't know where this is specifically coming from, if it's the hyperthermia or the other drugs. One thing to caution is that with MDMA, it's processed by a CYP enzyme called CYP2D6, and people who have depression can oftentimes be on medications like fluoxetine, paroxetine that are inhibitors of this, which means that you can have a greater experience with MDMA potentially if those are inhibited. But MDMA will also inhibit this after repeated uses. So hard to say. The next thing I wanted to talk to you briefly while we've got time is cocaine. This is a medication, a drug that in club scenarios is typically going to be in those nightclub scenarios. Not often is used in those outdoor music festivals. It's a natural product derived from the coca plant and presents itself with profound stimulation in the sympathomimetic realm. So you're going to see tachycardia, diaphoresis, and hypertension. But there are potentials to have psychosis from the profound dopamine release as well. And so you may see a patient present to the emergency department, present to the harm reduction area in a severely agitated state, clearly having psychosis. And we're going to treat those patients similar to the way we were with other presentations of sympathomimetic syndrome. Our first line therapy is going to be benzodiazepines. But cocaine itself produces some interesting effects. It's much more likely to cause seizure than a lot of other sympathomimetic drugs, and it causes vasoconstriction, meaning your blood vessels seize up and can cause a lot of consequences from that. Specifically, cocaine-associated chest pain is something you might deal with because it can cause coronary vasospasm. It can also cause stroke, both kinds, ischemic and hemorrhagic. And the way it's metabolized in co-ingestants like ethanol can prolong the effect of that for a long period of time. And so it may not be the same experience if they're mixing drugs and alcohol with their cocaine use that they had previously. So the number one thing is to use benzodiazepines to calm that psychosis down. And you can treat the chest pain that presents like any other acute coronary syndrome workup with a slight difference in that somebody, if you're about to activate a cath lab, you might want to try medication like benzodiazepines and nitroglycerin on that patient before sending them off to cath lab, because it could be a reversible vasospasm from the cocaine. So the guidelines are the same. One unique thing about cocaine is as an anesthetic, right? It started off that way, being used for eye surgeries, cataract surgeries, where it was initially really used medically. It is going to act on a sodium channel, and when sodium channels blockades occur, you can get a wide complex tachycardia on your EKG. That often can lead to a ventricular tachycardia. Well, what you can do for those, also calming down the norepinephrine surge that's released from cocaine, it's a mechanism of action, but we can use lidocaine and sodium bicarbonate to counteract that. Okay, so we treat cocaine with early aggressive symptomatic treatment as well. One contaminant in every one of these drugs is a common theme, has often contaminated substances in there. One thing that you should be aware of is levamisole. In some cases, up to 70% of cocaine seizures had this antihelminthic agent, levamisole, in it. And in people, it causes painful purpura. So there where you get a lack of blood flow, and you'll get some necrotic tissue. In specific, like end tissues, like the ears or maybe the elbows, you might see these. But also at some point after being exposed to this for weeks, your white cells really become affected. You lose them and you set yourself up, and people die from this from infection. And they also get a vasculitis, which you can test for. But if you see this constellation, low white counts, painful purpura, you think about levamisole in your cocaine users. GHB may be used as well, often thought of as potentially a date rape drug. It may be used in a lot less frequency than MDMA in club situations, because people may be balancing out their effects. They may want a more sedative experience, depending on what kind of club environment that they're going to. But GHB itself is a profound sedative. You can see here of these 88 presenters in this one particular study by Chin in 1998, you have the patients that arrive after a GHB exposure completely normal with a GCS of 15, but the vast majority of cases that are in any one particular spot are GCS3, the lowest possible coma score that you could have. So, and in between, it's a bit spread out. And GHB is like this. You will have a profound coma, be unable to sternally rub a patient, and then in a few hours, they're walking out of the ER on their own. It's an amazing phenomenon that happens with GHB, that very quick alertness. And that helps us determine, if we know that somebody is exposed to GHB, what to do that for that patient. And it's encouraged for you not to rush to intubate these patients because oftentimes even the ones that vomit won't necessarily aspirate. So if you put them in a recovery position, if you know it's GHB and you know they haven't had trauma, then and you need to expedite a workup otherwise, you may just watch them for a couple hours and they'll walk out of the ER in a few days. In this particular case, the patients that were intubated for airway protection, up to 18% of them, I believe, were extubated in the ER and discharged straight from the ER. They didn't have time to get them to the ICU. Ketamine is another drug that is often used there. And the highlights for ketamine is that it's known as a dissociative anesthetic when we use it in the emergency department for procedures, but it's really essentially acting anesthetic, and that particular way that it works is it basically causes your cortex to not register pain and sensory perception, and also for you not to be able to form memories. The way it works is against a receptor called NMDA, but it really works on a bunch of other ones. The things that you should be aware of with ketamine is something called an emergence reaction, where people get very agitated coming out of the experience. And that's just managed with benzodiazepines. And you might have people that come to you that are chronic ketamine users that have something called ketamine-induced uropathy, which is symptoms of a bladder infection chronically. The only way to treat that is to avoid ketamine use. And in some cases, such fibrous changes to the bladder occur that a person might need to have surgery. But typically in the ED, people recreationally using ketamine aren't going to be presenting because the half-life on it is about 15 minutes. So people will probably be back to somewhat normal status before they get to the ER. And when you're trying to choose a sedative agent, ketamine is a really good agent when it comes to hyperactive delirium, which is the term that has replaced agitated delirium and excited delirium. If de-escalation maneuvers don't work, ketamine is a fine, quick-acting medication for you to be able to give intramuscularly. But these other agents, droperidol, olanzapine, and midazolam, are advised by the latest ACEP policy put out in 2021. So these would be great agents for use to treat hyperactive delirium. Now, I know I went through that pretty quickly, and I lost track of our chat. So Megan, if there's any questions out there, I'm happy to answer those now. I think we've got a few minutes before the end.
Yep, we have a few questions here. So first question is there an increased risk with folks who are taking antidepressants with these serotonin enhancing drugs?
Yeah, so that's a very interesting debate there, because some users will say that they won't get the same experience if they haven't been abstinent of their SSRIs. Some SSRIs have a very high affinity for the SERT. It's the transporter for serotonin on the neuron, like paroxetine. Very, very specific, fluoxetine, very specific and have a high affinity. So it may be that in some cases, they may not have that experience at all because the MDMA can't get into the neuron to have that big release. In other cases, they will. But oftentimes when we're thinking about serotonin syndrome, you need to have a combination of drugs that are serotonergic to have that precipitated. So I would be very cautious for anybody on SSRIs in general to take MDMA or another serotonergic agent.
There's a question about, so when you were talking about using benzodiazepines, there was a question that came in on asking what if someone has benzos listed as an allergy?
Oh, yeah. It's pretty rare. It may be a specific one that they have that they are allergic to. You could potentially use ketamine as an agent to kind of reduce agitation as well in those particular cases. Sometimes that's synergistic, can help with seizures specifically. We often can add that on to people who are having withdrawal for alcohol. So you'd have to use other agents. And if it's really what you're trying to use for, you might be able to use some of your de-escalation techniques. If they're super hot, you could certainly get them in an ice bath and try to calm calm them down in other manners. Yeah. And I would avoid those classic butyrphones, antipsychotics to chill them out, because there's thought that they can reduce your seizure threshold. So I would choose maybe an olanzapine or a new generation antipsychotic. Potentially droperidol might be effective based on the data that we have, but there'd be other ways to keep them calm.
Perfect. Thank you. Another question, do you find fentanyl lacing club drugs? Which ones and how common is it?
Yeah, so there are a number of case reports in the literature of fentanyl kind of creeping in. And I don't have, I mean, fentanyl has made its way into all kinds of drugs, not necessarily club drugs. So at least in the last few years, fentanyl test strips and the knowledge that drugs can be contaminated with fentanyl has become much more available. So I would encourage, if you're in that environment, with any drug, particularly with a new source, that you have it tested before actually ingesting it. So MDMA could certainly have it. LSD might be a little less likely, but I even believe, and there's other drugs in that Brazilian case, they did find some fentanyl on those as well. So you have to be careful.
I'm not seeing any other questions here.
Okay.
I have one for you though, if you're willing to answer another one.
Sure,
oh, wait, hang on. Are test strips prohibited in club and festival environments under the rave law?
Yeah, so that's a very good question. A lot of club organizers interpret the rave law to specifically disallow fentanyl testing. Okay, they interpret that they don't want the liability to that, and they may not allow testing on site. But there might be other ways around that, and I'm not a lawyer or anything, so don't take that as protection. There is a group organizing to lobby Congress to get more clarity, or at least another letter from the DOJ to specifically say testing is safe to do, and a number of organizations are doing that at festivals. So you may before going to these festivals ask about what's available for testing, but you're kind of in a gray area, and it's up for interpretation. A lot of organizers don't want to do that.
Great, thank you. So my question for you is that, there's been a lot of information here directed towards people who might be, working at these events, helping out at harm reduction booths, or clinicians who might encounter these patients in emergency department settings. What would be your one takeaway you would want to provide people who may be interested or who are using club drugs?
Yeah. So I think a lot of it is reading and understanding about the particular drug that you're using. There's a lot of resources that you can use online to be able to kind of research that. But you have to understand that those aren't necessarily, they're not peer review literature usually when you're Googling a drug. And there might be a lot of information. So I would study as much as you can on that drug, because it could be, the last drug you ever take. The MDMA literature says that hypothermia can occur with as simple as one dose. And you don't know if you're going to be that person when you're experiencing it. So I would get, if I don't know the source and hadn't had it before, I would certainly try to get it tested at a known trusted site before ingesting it, and do it with people who can calm you down. A lot of cases, LSD is very safe. The literature where people die, it's often somebody having an acute psychosis and doing something that would kill anybody, jumping out of a window, or driving a car and crashing, doing things that if you did it in an environment where you were observed and had a friend that was able to calm you down, it wouldn't go badly. So and a lot of times it's, if you set the environment right, you have intentionality about it, you've studied what you're going to do, and it's safe, it may end up being safe. But it can't say every time it's going to be safe for a particular person. And then you don't know when you combine the other medications that you're on. So if you're somebody who's on a medication for a psychiatric condition and you try one of these drugs, there's very possible outcomes that are adverse to you. So you gotta go about it with an intentionality to be as safe as possible.
Thank you. Some great harm reduction messaging.
Yeah.
Alrighty, well, that is it for questions. If any of you viewers have questions after the fact, you can still put them into Q&A and chat, and I can pass them along to Dr. Patati. Otherwise, thank you, Dr. Patati, so much for taking time out of your day after you've already worked a full day. So thank you so much. We really appreciate all of your expertise and knowledge that you shared today.
All right. Thank you, Megan. Thanks to everybody. Bye.
Thanks, everyone. We'll see you tomorrow.